Now this lecture is on Graves' orbitopathy, just as continuation of my ophthalmic plastic surgery course. The thyroid gland is the one in the front of the neck. It is under the control of the hypothalamus. The hypothalamus controls the anterior pituitary, and the anterior pituitary controls. So the hypothalamus secretes the thyrotropin releasing hormone, which controls the anterior pituitary gland. Anterior pituitary gland secretes the TSH, thyroid stimulating hormone, that controls the thyroid with positive and negative feedbacks. And the thyroid secretes two hormones, the T3, triiodothyronine, and thyroxine T4, tetraiodothyronine. Both help in increasing and aiding the metabolism with growth and development, and increasing the catecholamine effect in the body. Again, the hypothalamus secreting a thyroid releasing hormone to the pituitary, and the pituitary secreting the TSH with the negative feedback, meaning if the secretions of the thyroid are high, this gives the negative feedback on TSH, which becomes low. The same mechanism works on the hypothalamus. What's the meaning of goiter? Goiter is from the Latin gutturia, meaning the throat. So goiter is the throat, an enlargement in the throat. And it was first described by a Persian physician in the 11th century, and then by an Irish physician and a German physician. The one very famous to us is Graves. That's why we call it Graves' orbitopathy. And Graves is with S. That means the apostrophe has to be after this. The strange thing is that in France, they call it the maladie de Basdo, and Basdo is the German physician who described the disease almost 5 years apart from the Irish physician. So I'm just trying to let you know that in another Francophone culture, they have another name for it. Here is the mass in the throat, that is goiter. And when it affects the globe, we call it Graves' orbitopathy. So this is Graves' disease. And when it affects the ophthalmic system, we call it Graves' orbitopathy. Here in this lecture, we have the pathophysiology, the clinical evaluation, the thyroid optic neuropathy, the severity and classification of activity, and the radiological imaging. And we start by pathophysiology. This is the commonest cause of adult exophthalmos. Females are often more affected, almost 8-fold in the age group of 20 to 45. Presenting by hyperthyroid, euthyroid, or hypothyroid profile, depending on the original etiology. The differentiating point is that the tendons are not inflamed, in contrast to Hashimoto's or Hashimoto's thyroiditis. I'm sorry, it's not myositis. So the tendons are not inflamed. If you have B-scan of the orbit, you find the tendons are not thickened. If thickened, think of another cause than the Graves' orbitopathy. The muscles show inflammatory infiltration by lymphocytes with marked edema. So the hormones T3 and T4 lead to orbital fat volume increase and muscle hypertrophy, and both increase the intraorbital pressure. From the increased intraorbital pressure or other manifestations occur. It's important to know the thyroid stimulating hormone receptor antibody. TSH-R antibody. The thyroid stimulating hormone, which is the TRH, which is secreted from the pituitary, has receptors in the thyroid, and these receptors might have antibodies, and these antibodies circulate in the blood, and they are responsible for the clinical manifestations of Graves' disease. They are a very specific biomarker, but also found in Hashimoto's thyroiditis. TSH receptor antibodies is a test that you can take in a blood sample, but it's rather expensive, not readily available, takes maybe a week or 2 weeks to get the results back, as the kits have to be conglomerated. Under the microscope, the eyelid skin shows chronic dermatitis, and clinically speaking, you have to take history, and usually there is history of pain preceding the mode of onset, but not in all cases. And you have to ask about the direction of proptosis or exophthalmos. It's usually axial to the front, and the severity depends on the degree of pushing from behind. We use the Hertel's exophthalmometer, or we may use a simple ruler can do. Hertel's exophthalmometer, you read the area of proptosis in the mirror against a ruler, and you have to position your eyes in the same level, not proceeding or receding on the patient. This is the Hertel's exophthalmometer with different versions. And this is the simple ruler where you can start measuring from the lateral bony canthus till the tip of the cornea. Here, the 0 is the bone, at the bone, and here you can read 13 millimeter, 14 at the tip of the cornea. There are different hypotheses, but with limited evidence for the proptosis. Acute active phase is usually due to orbital inflammation and congestion, and a chronic inactive phase is due to tissue expansion and fibrosis. So there is inflammation and edema fluid in the beginning, and this leads to tissue expansion with inlay of fibroblasts later on. Clinically, there are 5 areas. Lid retraction. Sorry, lid retraction is seen in more than 80% of the cases, and in this way, it is the most consistent manifestation of Graves' orbitopathy. Exophthalmos is seen in only 1/3 of the cases of Graves' disease. Soft tissue involvement depends on the longevity, duration of lid retraction. Restrictive myopathy in 1/3, and optic neuropathy in only 5% of the cases. So you learn it this way. The most important thing is lid retraction with soft tissue involvement. Exophthalmos and restrictive myopathy is in 1/3 of the cases. This is the second common, and fortunately, the rarest is optic neuropathy in 5 to 7% only. Lid retraction is due to levator overaction and molars muscle contraction. We all know that the molars muscle is a part of the levator palpebrae superioris that's under the control of the sympathetic. That is, the catecholamines are the mediators responsible for its action. The signs resulting from levator overaction are the Dalrymple sign, which is lid retraction in the primary gaze, von Gravis, retarded descent of the upper lid. Kocher's sign means staring look. So if you find the upper lid retracted when the patient is looking directly forward, this is the Dalrymple's sign. Von Gravis means when the patient starts to move the eye down, the upper lid does not follow it directly, and Kocher sign means a staring look, that is both upper and lower lid are retracted. It has an insidious onset. That means it might occur between day and night. And it's first recognized not by the patient, but by others. And the gravest stare has a lateral flare that is accentuated with emotion and conveying anger. Usually the lateral part of the, my video is on now, the lateral part of the both lids shows a flare. That means the lateral part is more apart rather than a medial part, and this is accentuated with emotions. Now, if you have a CT done in eyelid retraction, there is a strong correlation with an enlargement of the levator palpebral superioris, as it is the muscle most targeted by the autoantibodies. And in 15% of the patients, the inferior rectus might be enlarged as well. Here is, as you can see, the upper lid is in touch with the limbus. It's usually covering 1/5. And the lower lid is showing some scleral show. And here's the sign of lateral flare that I was talking about. Here, the lid retraction is more. Exophthalmos is axial, bilateral, but it starts unilaterally. Never forget that. It's the second most common, as we said, as it affects 1/3 of the cases. The lid retraction is more in occurrence. If you would like to differentiate between, if I ask you how to differentiate between lid retraction and proptosis, you must say that the upper lid is showing here a scleral show, and this means a lid retraction. But if the lower lid is not showing a scleral show, so this is not proptosis. The meaning is in proptosis, both eyelids are apart from the limbus, but in a lid retraction, it's only the upper lid. So exophthalmos is from expansion of orbital fat. There is a restricted Bell's phenomenon that may lead to corneal exposure. Here, this is very evident. Big scleral show in both the upper and lower lids, and here the same. Choroidal folds, I explained that in pathology of the orbit. We said that there are areas that are dark and areas that are light. These are called the crests and the troughs. And if these involve the fovea, they may affect the vision. And we explained this by describing how the crest and how the trough form. And we said that the receptors are dependent on the retinal pigment epithelial cells. And if these get apart at the fovea, this may affect vision. And there's a common question that we ask the undergraduate students, and I'm sure you all know, when we ask about drop of vision in thyroid patients, and you must remember that there is optic nerve compression, and you must remember that there is optic neuropathy, and there is choroidal folds. These are two important causes of drop of vision apart from corneal exposure. So there are three etiologies. Number one is corneal exposure. It's not in all patients, not even in the whole 80% patients who have a lid retraction. And the second thing is compression of the optic nerve, which we are going to describe later. And the third thing is choroidal folds involving the fovea. This is soft tissue affection. One more patient with exophthalmos. Restrictive myopathy occurs in only 1/3 of the patients, as we said. And there is a classification known as Bunn-Gorman scale, explaining that there are 5 levels of restrictive myopathy, going from no diplopia to constant diplopia, not correctable with prisms. And the first muscle to be affected, usually, as we said, is the inferior rectus, leading to defective elevation. And the last muscle is the lateral rectus with defective adduction. Optic neuropathy occurs in 5% of cases, with loss of central vision, which is subtle in early stages. And it occurs in the form of the symptom of desaturation of colors with an afferent pupillary defect and disc edema. Afferent pupillary defect occurs in 40% of cases of optic neuropathy and disc edema in 60% of cases. How to suspect Graves orbitopathy leading to optic neuropathy? You have the disease, you notice visual impairment, you find no other cause of visual impairment, no corneal exposure, no choroidal folds, so you suspect optic neuropathy. You need a radiologic evidence of optic neuropathy, like compression or stretching. No compression or stretching, you exclude optic neuropathy, but if you find it, so the thyroid etiology of optic neuropathy is most likely. Many signs of thyroid Graves orbitopathy have been described to us. The most important are the ones that we describe: the dull impulse and the Kocher sign. Kocher sign is a spastic or spasmodic retraction of the upper eyelid on fixation, the staring look, and von Graefe sign. This is a patient with orbitopathy that we operated upon, doing 3-wall decompression, leading to retraction of the globe pre and post, as you can see. Now, an important point is pediatric Graves orbitopathy, and in children, the symptoms are mild. There is no restriction, no vision affection, no optic neuropathy, so mild lid retraction, mild soft tissue affection, and some may have severe disfigurement and corneal exposure and may benefit from orbital decompression, but this is very rare. Remember always that it is a very mild disease with no muscle restriction. Optic neuropathy is due to compression, stretching, and retrobulbar pressure, inflammation. No histologic study has been done for this so far. The treatment is via intravenous methylprednisolone or urgent decompression or invasive surgery to avoid corneal breakdown. High doses of methylprednisolone, like 1 gram per day for 3 consecutive days, or on alternate days during the first week. We don't do this. We shift the patient to the endocrinologist or the neurologist to manage. If there is no response or poor response or rapid deterioration of vision, urgent decompression of the orbit might be an important resolution. And severe corneal exposure, if it occurs, we have to treat this medically by things like tersoraphy or moist chamber or whatever to cover the cornea and avoid corneal melting down. When you treat with methylprednisolone, there is a rule with the endocrinologists: if intervention does not result in improvement within 2 weeks, you give a second course, but with a maximum cumulative dose of 8 grams. That is twice of 4 days courses. Radiotherapy has a delayed effect, and there is a very important thing now stressed in the literature, is that smoking exaggerates the condition of optic neuropathy or even proptosis, and you have to strongly advise your patient to stop smoking. Now, the treatment of optic neuropathy, as we said, is started by high pulsed dose of 1 gram methylprednisolone. No activity, so the patient is rehabilitated by cosmetic surgery or so on, and he or she is healed. If you have poor response after 2 weeks, you have to repeat the treatment, and if no response, you have to do orbital decompression. And usually, if there is poor response, you repeat the methylprednisolone and use additional orbital decompression. It's usually a big problem in this condition because orbital decompression is a very, very disfiguring and suffering surgery for the patient. And when you do it with no result, there is a big disappointment. It's an example of orbital decompression that I did on a young chap with better results post-operative. As we described before, in the course of orbital surgery, I'm sorry, here is the medial wall that can be decompressed, removed, lateral wall, and the floor, but you cannot touch the roof as to the effect of gravity where the frontal lobe might herniate, frontal lobe of the brain. This video is shown here on permission of its producer, Dr. Taban. Immunosuppressive therapy for thyroid is the most important thing nowadays. We use, you can consider steroids as a part of immunosuppressive therapy, or methotrexate, or tumor necrosis factor inhibitors. They have names, but the most recent drug that has been approved by the FDA in December 2019 is teprotumumab, or Tepezza. You have to remember this name. It's a very expensive drug. The price is almost $10,000 per injection. It's extremely expensive. It is a monoclonal antibody. Used as 8 infusions once every 3 weeks. It's a very expensive course, but it is definitely a definite treatment for exophthalmos. So we use antibiotic. We use antimetabolites. We start by steroids. We use polyclonal antibodies, cytokine production or action modification, and cytotoxic drugs. The 4th International Symposium on Thyroid Eye Disease Society that was held in London in 2016 described the severity and classification of activity according to 6 systems. I am going to touch these briefly. Rundle's curve is the first one, and actually it shows the activity of any active disease in the body, not necessarily thyroid. It starts with an active phase with the signs and symptoms up to a max, and then they calm down but stay at a stationary level. This stationary level might be lowered by undergoing surgery or readaptation. So it plots change in the severity over time. It's a biphasic course, progressive and quiescent inactive courses that might be modified by treatment. The second is no specs. It's called no specs, just like a mnemonic to remember. It graves orbitopathy, symptoms and signs, as N for no signs, O for only signs, no symptoms. You see it, but the patient does not feel it. S for soft tissue, symptoms. P is for proptosis, E for extraocular muscle involvement, C for corneal involvement, and S is for sight or vision loss. No specs. European Group on Graves Orbitopathy, or EUGOGO, is based on 3 management categories: mild disease, moderate to severe, and very serious. And there is a distinction between the mild and moderate disease, but actually it's not very precise. And the other one is clinical activity score. It's a score of periocular inflammatory features proposed by Moritz et al. There are 7 periocular soft tissue inflammatory responses and signs, and you mark each of these giving a mark out of 7. This is an isolated right eyelid retraction, and this is a CT scan of thickened levator aponeurosis near its insertion, and other extraocular muscles are normal. Now the visa classification, which is the most recent and most complicated as well, it depends on vision, inflammation, squint or strabismus, and the appearance. And from scores on a sheet, you get a final disease grade. It's a rather complicated one. If you would like to classify your condition, you have to use a sheet and a checklist. Now, the final thing in this lecture is the radiological imaging, and it's important to know how radiologists tend to diagnose exophthalmos. First, thickening of the muscles on a CT scan or a B-scan ultrasonography. Here's the muscle belly of the medial rectus is very thickened, and here are all the muscles are thickened. Of course, this is the cause of increased orbital volume. Now we take the interzygomatic line as an imaginary line drawn between the zygomatic borders and the distance between the apex of the globe, this here A, and the interzygomatic line. If more than 22 millimeters, or if there is a symmetry between the two sides, that is more 2 millimeter difference, is pathologic. And the distance between the interzygomatic line and the posterior sclera is the B here, must be less than 1/3 of the globe behind the interzygomatic line, which is compatible with exophthalmos. So on a CT, you take the interzygomatic line and you measure the anterior part of the globe in front of it. If it is more than 22 millimeters, or if it is with a difference of more than 2 millimeters between the two globes, this is pathological and diagnostic of exophthalmos. And the distance between the interzygomatic line and the posterior pole of the globe, if it is less than 1/3 of the globe diameter, this is again diagnostic of exophthalmos. There are more measures like the Barrett's muscle index. I'm not going to bother you with the details. You can read it on the slide when you see it on my YouTube channel for more assessment of exophthalmos. So thank you very much, and I am open for your questions now. You can unmute yourself, or please, you may write on chat.